I welcome especially Dr. Alison Krentel, and I extend my gratitude for doing this lecture for us. And this is the lecture series by MERA-India, which is Malaria Elimination Research Alliance. So this is a special consortium. It's a vehicle for supporting and funding operational research against malaria elimination. But besides malaria, this series of talk, we would like to focus on the other infectious diseases as well. And elimination science goes beyond particular disease. Common principles are there, and how we need to move in elimination is can be different from control of a particular disease. And countries like India and other similar developing countries have their own challenges. So these kind of different talks, like we had previous speakers also on speaking on visceral leishmaniasis, speaking on COVID, speaking on vaccines, and many other different topics. It gave us a very good insight into different diseases and how do we manage them, especially milieu like India. So I really welcome you, Dr. Alison, and thank you for doing this for us. I remember catching up in a WHO meeting when I asked for a card from you. I have read your papers. And lymphatic filariasis, especially, I'm particularly quite involved in it from research side also. So from Indian Council of Medical Research also, I extend a warm welcome. And I also welcome all the participants, which are from very different organizations and institutes, including medical colleges and other research bodies, besides ICMR and our own institutes. Now, giving a quick brief on Dr. Alison Krentel. She is an associate professor in the School of Epidemiology and Public Health, University of Ottawa. Your expertise is global disease elimination programs, especially talking about community management and mobilization, community engagements on entities. And yesterday night, I was just going through the list of papers which you have written, and I was very, very impressed. And it took some time also to grasp them in their entirety. So today your topic is lymphatic filariasis. We are so happy to have you here. And Sachin will discuss a little more about it. Thank you so much once again. I'm very eager to listen to you. Thank you.
Thank you very much. Thank you for the warm welcome. And I do remember sitting next to you in Delhi. I guess it was about a year ago. I think it was June a year ago, actually, that we were there. Shall I share my screen?
So before we start, I welcome all the participants, Dr. Alison and other distinguished members here from MERA-India, from National Institute of Malaria Research, and from ICMR family. And as Dr. Rahi already mentioned, I would like to give you an official introduction, a brief introduction of Dr. Alison Krentel. She is an accomplished researcher and consultant in the field of public health, with an extensive experience working in over 14 countries across Africa, Southeast Asia, Latin America, and Western Pacific. Her research interests revolve around fostering community engagement, utilizing implementation research to strengthen health system, and translating research findings into practical programmatic actions. Currently, she is an associate professor in the School of Epidemiology and Public Health at University of Ottawa. Additionally, she holds a senior investigator position with the Bruyère Research Institute in Canada. She has been granted an honorary fellowship with prestigious London School of Hygiene and Tropical Medicine, and holds the role of Senior Research Fellow at WHO Collaborating Center for Knowledge Translation, Technology Assessment for Health Equity. She obtained her Master of Science in Public Health in 1999 and completed her PhD in 2008. And these both from London School of Hygiene and Tropical Medicine in United Kingdom. Throughout her career, she has served as a consultant for esteemed organizations such as WHO, Pan American Health Organization, UNICEF, Task Force for Global Health, and others. Furthermore, she also leads the THREADS lab as a principal investigator. So with this brief introduction, I request Professor Alison to start the talks. All yours. Thank you very much.
Thank you so much. It's a pleasure to be here. So thank you very much for the invitation. And I will get started. As I mentioned, it is early here, so as I said to Dr. Rahi, my apologies in advance, but it's a delight for me to be here, and thank you so much for the invitation. So the title of my talk this morning, and I just want to confirm that you're able to see the slides. I believe you can, but okay, excellent. So I will be speaking about lymphatic filariasis as a public health problem and talk about some of the current global challenges. And I will address these from a global standpoint, but I think they're relevant for India as well. And as Dr. Rahi mentioned in the beginning, although I'll be speaking from the perspective of LF, many of the challenges that we face in the neglected tropical disease community can also be applied to other areas where you're seeking to eliminate infectious diseases. So I think you'll find hopefully some of this will sound familiar as you think about some of the challenges you may face in malaria, for example, or other infectious diseases. So the outline of my talk today, I'll just very briefly, I know that many of you probably even have more experience than me in lymphatic filariasis, but I will introduce the disease very quickly, share some of the global goals of what we're aiming towards within the new WHO roadmap. And then I'd like to introduce the equity effectiveness ladder as a framework for us to think about some of the challenges that we face towards elimination. And then specifically, we'll look at some health system challenges and community challenges. And I'll aim to keep my remarks around 30 minutes so that we've got time for questions at the end. So lymphatic filariasis itself is an ancient disease. There's evidence from 6th century India and also subsequent from that, different times that the disease was recorded in India. It is a disease of low mortality, so it's not a disease that causes death per se, but it has high morbidity due to the clinical manifestations of the disease, which can cause lymphedema and hydrocele and elephantiasis as well. The impact of filariasis inhibits development at the community level, development at the household level, and it has strong links with poverty and social stigma. So individuals who are affected with the clinical long-term manifestations of disease, they may, for example, a woman may be ostracized and be difficult to marry. A man may find difficulty seeking economic income for his family. So there are lots of issues around social stigma and poverty and mental health that we now are associating more and more with lymphatic filariasis. So here's a map of people requiring mass drug administration in 2019. So the countries in the darker green are those where more people require preventive chemotherapy through mass drug administration, which we're going to talk about today. And you can see in the Southeast Asian region, India, Indonesia, in the Western Pacific, Papua New Guinea, particularly India and Indonesia, retain a significant burden globally of lymphatic filariasis and numbers of people at risk for disease. In the Americas, the disease has largely been eliminated as a public health problem. Just Guyana and Haiti remain in that region. And then you can see across the sub-Saharan African region, countries that still require mass drug administration or preventive chemotherapy. So in India particularly, 670 million people are living at risk in the country. This is a map taken from a paper in 2022. So it may have even changed in the last 2 years. Around 174 districts are undergoing mass drug administration in India, and you can see those are in the yellow. Those are colored yellow, where MDA is proposed, and those that are green in the map are currently under some form of evaluation, so either treatment assessment or a surveillance. India represents 40% of the global burden of disease. So we often say if we do not achieve success of elimination of lymphatic filariasis in India, we will not achieve global success. So it's extremely important that this program does well in India and succeeds. The program was launched in 2004, and a significant moment in 2018, and I'll talk a little bit more about this treatment, when triple drug therapy, ivermectin, DEC, and albendazole was launched in 2018 and accepted for use in India subsequently. And so this has provided an opportunity to accelerate elimination in many districts in India. So the elimination goal currently is for 2030. So just very briefly, looking at the life cycle of lymphatic filariasis, of the parasite. This represents the parasite Wuchereria bancrofti. There are two other species, Bruyère timori and Bruyère malay, which are largely found in Indonesia, Malaysia, Timor-Leste. So you can see whoops, sorry. I thought I was getting my pointer. Here we go. So you can see here that a mosquito takes the blood meal, and at this point, larvae enter into the skin of the individual, and as they move into the human host, you can see that they migrate to the lymphatic system, where they grow into adults. And here you can see is a worm nest. The adult lifespan of these worms is around 4 to 6 years, and this is important, you'll see in subsequent slides. So when the adult worms are living in the lymphatic system, they produce microfilaria, which then circulate in the peripheral blood, and are then taken up by mosquitoes subsequently. And you can see, I won't go into the mosquito stages. So there are different kinds of mosquitoes that transmit lymphatic filariasis. Many of them are night biting, and so often the only way for us actually to see circulating microfilaria is at nighttime. But that's not always the case. But in many cases, we see them at night. So the global program to eliminate lymphatic filariasis has two pillars. The first is to reduce parasite levels in the blood through yearly mass drug administration, and that's largely where I will be speaking about today, is around MDA. The second is to provide morbidity management to alleviate suffering for those who already have disease. And this second point is very important because, as you can see with the implication of the worms in the lymphatic system, over time, they damage that system, and that's what causes hydrocele or lymphedema to appear. Over time, if those conditions are not well managed, they can be quite disabling. While there is surgery for hydrocele, for lymphedema or elephantiasis, as many of you may already know, the best advice that we can give right now is self-care, cleaning, and ensuring that there aren't secondary infections. And India actually has a wonderful history of creation of self-help groups for individuals who are suffering from the disease. So in order to interrupt transmission, you begin with mapping of the disease prevalence in the district or the implementation unit. In India now, this has shifted to the block level. Once an area is determined to be endemic, then you can implement mass drug administration, and also you should begin your morbidity management and disability prevention. And again, in India, there's been some great evidence of the use of morbidity management and self-care groups in actually encouraging people to take treatment during MDA. After the period of mass drug administration has finished, then you move into surveillance and verification. So many of the districts, for example, in India that have stopped MDA have moved into this surveillance phase where you're monitoring for transmission. So what is mass drug administration? Many of you probably are already familiar with this. It is a delivery of safe and inexpensive, in this case, free treatments You give it to people without an individual diagnosis. So if an area is considered to be endemic, then everyone who is eligible will receive the treatment. And there are eligibility criteria for mass drug administration for lymphatic filariasis, depending on the treatment that you give. But generally, pregnant women are exempt from treatment. Individuals with serious illness, and children under 5 if it's IDA, or under 2 if it's DEC albendazole. So the important thing here is that the success of MDA depends on the participation of the whole community. We have to have a coverage target of over 65% in order for MDA to be effective. So if we think of the epidemiologic triad, mass drug administration basically deals with the host and the agent. It doesn't do very much, we don't do very much vector control, actually, in terms of our approach to eliminate MDA. The theory is that by addressing the disease in the host, then we will reduce it in the vector over time. So how does it work? You can see, remember that the adult worms live for a period of 4 to 6 years, which is why we recommend mass drug administration between 4 to 6 years, as we want those worms to die and no new microfilaria to develop into adult worms. And so you can see that over time, the MDA comes in and reduces that annual transmission potential, but it takes some time in order for that adult worm population to start dying. And as it does, then we come to a level where we're not producing new microfilaria. And this is largely, this particular graph here is illustrating the 2-drug regimen, so DEC and albendazole, that has been used in India historically. When we introduce the triple drug therapy, you can see here, if you look at this graph on the left, this is the 3-drug regimen. You can see here that the microfilaria has a much more dramatic reduction, and it does not bounce back. So even after 36 months of treatment, only a few individuals have shown evidence of microfilaria rebound. And what we think is going on here is that there's some sterilization of the adult worm with the 3-drug regimen. And so effectively, it would accelerate that graph that I showed previously in terms of our aim towards elimination. So what I really want to speak about today are a lot of the challenges that we face. So I've explained to you kind of the theory of how mass drug administration works, why we use it for the elimination of lymphatic filariasis, and now I'd like to spend a little bit of time talking about some of the challenges that we face reaching our targets. So new medicines, diagnostics, vaccines. So in this case, IDA, for example, there's a lot that happens between the introduction of those treatments and this final point in the patients. And again, it's community really in my talk today. So there's a lot that happens along this pathway, and I'm not really going to talk about any of this, but I want to just illustrate that it's really there's a lot that happens before, as we prepare for mass drug administration and as we get ready to deliver the treatment to communities. So my talk today will largely focus in this area around the health service delivery to community members. But I want you to just be aware, as many of you already are, about the other phases that occur before we actually get to the mass drug administration. And some of these can be quite inhibiting to our success. So what happens at the community and health system level? So just in a kind of simple illustration, volunteers, in the case in India, Ashas or Anganwadi workers will deliver safe and free tablets. We often call these community drug distributors. They bring the tablets to their catchment areas. Usually they're allocated about 5 days to work in order to do this. That, of course, varies by location and by country. They deliver their tablets either house to house or at distribution points. And as I mentioned earlier, they need to treat at least 65% of the total population every year for 4 to 6 years. So they need to reach this target at a very minimum for a sustained period of time. So what happens when we actually introduce this treatment into the system? So we know that we have a treatment that works, and I showed you that graph where you have this reduction of microfilaria and the death or sterilization of the adult worm. And so we know that it's efficacious. We know that mass drug administration works. There are 17 countries that have currently eliminated lymphatic filariasis, so we know that it is possible and that MDA works. Unfortunately, when we enter into the system, there are certain points along the pathway where we start to lose the effectiveness of our treatment. So I'm going to talk about each of these individually. So access, individuals' access to the treatment at hand, the targeting accuracy, so the way that individuals are selected for treatment, the compliance of the provider. So does the ASHA, the Anganwadi, the nurse actually comply with WHO guidelines on the use of the treatment? Also, how does the individual adhere to the treatment as it is supposed to be taken? And as you see, as we go through this process, we have a reduction in effectiveness. And these are generally factors that are related to the health system, to partnership at the individual level. And you really could apply this ladder to any public health program that you're rolling out through the system or through the community and identify at which point are you having the most significant challenge. So if we talk about access to treatment, these are just some of the challenges that we may face in identifying individuals that need to receive mass drug administration for lymphatic filariasis. One of the common ones that we hear is that the distributor never came to my house, and so I never was offered the opportunity to take the treatment. It's very difficult also to understand how many people are living sometimes in a village or in a community. So we have insufficient census numbers, and that may result in under procurement, which can result in drug stockouts during the mass drug administration. There are very challenging remote locations for people. We often time the mass drug administration at the wrong time. So it happens during harvest season or during planting or during school holidays or festivals. And so community members may simply not be home or be busy or not interested in the MDA when it occurs. There are also forms of discrimination, and increasingly in the research that we do, we come across groups of individuals that are excluded by the health system in terms of receiving MDA. Most recently, in some research that we're doing, palm plantations, for example, in parts of Indonesia and Papua New Guinea, they are not, those individuals living on those plantations are not routinely included in MDA, just as an example. So that can inhibit our progress towards elimination. Secondly is our targeting accuracy. And this is some research that we did in Indonesia several years ago. And we asked the healthcare providers who was eligible and who was ineligible for taking LF drugs. And what is important here is that only 70% knew that pregnant women were ineligible. And that is important because pregnant women are absolutely ineligible for treatment. And so the fact that our distributors weren't aware of that as well around age was also concerning, that they not quite 50% knew that children should be exempted from treatment under 2. Persons aged over 75 years, this is not actually a WHO criteria. but this was something that was introduced in Indonesia. And so you can see when you have this variation of eligibility, it affects that coverage level of 65% because you're not able to reach the targets as easily. At the provider level, we see that there's variation in the training of our healthcare providers and our distributors. So those ASHA or Anganwadi workers, training is variable, and it very much depends on the state or the district and how they are going to be doing that. If they do it on an annual basis, is it cascade training or not? We also see that directly observed treatment is not followed, and I'll speak a little bit more about how that impacts the coverage compliance gap. We also see that drug distributors are not the same, and there's a real different profile between the urban and rural areas, and the way that we actually select them is not always sufficient. This is perhaps not as important an issue in India, given that largely you're using ASHA and Anganwadi workers in the community for distribution of LF tablets, but it's important in other parts of the world where LF elimination is occurring. So I made reference to the coverage compliance gap, and this was first actually termed by Babu and Babu, Indian researchers in 2014, and they were the first ones who who first described this this idea. And basically, the global program was recording drugs that were received as swallowed drugs. And that was based on the assumption that directly observed therapy was occurring. And so that if I brought treatment to someone's household, they swallowed it in front of me. And so I could tick the box that individual had both received and swallowed the pills. But actually, upon looking at, and in this particular review, they looked at 32 studies, and actually they identified this important gap, which was the number of people who received pills was not the number of people who swallowed pills. And so they demonstrated that compliance was actually around 22% lower across those 32 studies. And that was important because that actually drove that coverage estimation below 65%, which makes it difficult then to achieve the goals that we need to achieve within the time period. Another challenge is professionalism. And this was very apparent in some research that we did that included a site in India around the professionalism of that drug distributor. So that individual, that interface right at the community level, how patient is that individual with the community member? Do they actually listen to the questions that are being asked? Do they have answers? Do they know where to get answers? Do they show empathy or caring for the people in their community that they're working with? Is their appearance professional when they actually come to households to deliver treatment? And also, we noted in this particular research that by waiting for people to take the treatment in a DOT or directly observed therapy, that it actually demonstrated that the distributor was taking responsibility for the outcome of the distribution. And so, having a little bit more time to answer questions and to watch the individual take the treatment was really highly perceived by members of the community. At the patient level, I've already highlighted that some groups don't receive treatment for whatever reason. We often find that community members are unaware about mass drug administration. Unfortunately, social mobilization is often insufficient to alert people to MDA that's coming, to tell them where to get the treatment, and also to instruct them on how to take the pills. We often make an assumption as health professionals that people will know what to do when they're given pills. But when you're given a handful of pills, in the case of the triple drug therapy, you may have 7, 8, 9 pills to take. People don't necessarily understand how to take those pills. And so it's important for us also to teach people how to do that in our information. One of the important issues and challenges that we face in LF elimination is around adverse events. So the number of pills, this is my hand, actually this is my colleague's hand. It's not my hand. So often I have my own hand, but this is a gentleman who's about 6 foot tall. That's his treatment. It's a lot of pills, and this is the triple drug therapy for lymphatic filariasis. So we initially thought that the number of pills was going to be a really important inhibiting factor, but we actually found in our research that it was not, particularly if we explain what the pills are for and why you have to take the 3 different kinds altogether. But adverse events remain a common reason why people don't participate in mass drug administration. So as you saw in that initial slide about how LF is transmitted, when an individual has microfilaria and adult worms in their body, when they actually take the treatment, the body has a response. The worms have a response, and the body has a response to the worms dying or being affected. And so you can have fever, you can have dizziness, you may be sleepy, but the adverse events are usually quickly self-resolving within 24 to 48 hours. However, individuals sometimes are still, the rumors are there, people experience them, and they become fearful. It's also important to note that we deliver albendazole at the same time, which is very effective against soil-transmitted helminths, and so the body will also react to the death of those worms as well. So this is an interesting slide. This is from some of our research that also included a site in Karnataka. And what we saw was that we asked people, this is in our survey, did you feel better after treatment? What's interesting here is that men actually felt better than women. And when we asked if they experienced, so we asked them, did you experience any adverse events? We saw here that women self-reported experience adverse events more than men. So this is quite interesting. When we look at the safety trial data, so this is a clinical assessment of the adverse events, we actually, the researchers there demonstrated that men do have less clinical adverse events than women do. So our actual survey results confirmed that when we asked individuals to self-report. What's interesting here is that only 12% were assessed with a clinical adverse event, and most of those were grade 1. So what's interesting is that people's self-perception of having an adverse event is much higher than what they actually experience clinically. And so there's some phenomenon going on in the community that people, when they're told you may experience an adverse event, actually report that they have an adverse event when they don't. And so we find that adverse events present a really important challenge to our elimination programs. The never treated, and I'm just getting towards the end here, the never treated, this is an important new group of individuals that have been identified in the last, I would say, several years. These are people who have never consumed treatment during any round of MDA, and we usually identify that through this question here, and it's been validated in different parts of the world, including in India. And what we know about the never treated, urban regions tend to have the highest numbers. There's a lot of regional variation. Even within a district, you may have certain blocks or areas where you have higher levels of never treatment than others. We also see some household clustering where if someone in a household has been never treated, there are likely others within the household that also haven't taken the pills. It's consistently associated with lower acceptability. So people generally who have never been treated also don't have a high acceptability of MDA. They also report levels of don't know. They don't know about LF transmission. They don't know about asymptomatic nature of LF. So we've seen this consistently across different sites, and there's something about those individuals that they seem to be missed by the education and social mobilization, and that tends to translate into really having no knowledge at all about the disease or the treatment itself. We see a lot of variation across age, income, and gender, so we can't really make any specific global trends on that, but those are important factors. And this is something that's increasingly being studied in India. to understand the role of never treatment and who we're actually missing completely in our mass drug administration programs. There is a direct relationship with infection, and there are some papers there that I've listed that show that relationship between never treatment and parasite infection. So I'm not going to spend very much time on the contextual factors. That could be another lecture, to be frank. But this is from the Implementation Research Toolkit. And these are some of the contextual factors that we can consider that affect that whole system and community rollout. Within the LF MDA, these are just some that we've documented in our research and experience. Communities often are not part of the conversation when it comes to MDA rollout, and so we don't see high levels of community ownership, and so they are in the receiving end of the MDA rather than on the driving end. There are often much more pressing health priorities in a community, and that may result also in a low government prioritization of LFMDA. And so these are important challenges that need to be overcome when we're reaching towards elimination. As I mentioned earlier, urban populations create a lot of challenges, and globally, those are areas where we really need increased innovation in order to reach people living in urban environments. Cultural, social norms, gender dynamics, these can present real challenges to MDA depending on, again, the site and context. And then our complex situations, climate change, internally displaced people, insecurity. These can really create situations that make it much more difficult for us to deliver MDA effectively. So the context of implementation is complex. At each of those points along that equity effectiveness ladder, there is complexity. Once we enter our product, in this case, our drugs, into the systems, different challenges arise which lower their equity effectiveness. MDA programs need to remain flexible to changing contexts, and particularly as we approach the end game, new challenges are needed where we need to think more innovatively and learn from other programs. What can we learn from malaria? What can we learn from vaccination, from polio? India has made a lot of gains by learning from how polio has been, where success has happened in polio. Success is possible, and I believe this is my last slide. There has been a lot of progress since the global program was launched. Over 9 billion treatments have been delivered, and we continue to see successes as we move towards elimination. So thank you very much, and I hope I went a wee bit over, but hopefully we'll have some time for questions. So thanks for your attention.
Thank you very much for the wonderful talk, and you have covered everything, especially in context of India. So as we mentioned also, and this is the trend, we generally give some time to the audience to ask the question. But I can see one question here, which is if you allow me to read, is it possible to design site-specific injectables for affected areas? This is the question.
Yeah, it's a good question, and I think that well, at the moment, the treatment that we have available is in the pill or tablet form, and those treatments are donated generally. So and so in India, for example, it would be DEC, diethylcarbamazine, citrate, albendazole, and ivermectin. So we do use tablets right now. Unfortunately, in the neglected tropical diseases, and lymphatic filariasis would be the same, there's not a lot of motivation for R&D of new vaccines, diagnostics, treatments. And I think that you probably would argue the same in malaria. But in the neglected tropical diseases, unfortunately, there's not sufficient R&D. Excuse me. So at the moment, I am not aware of any injectables that could be used for lymphatic filariasis, but others on the call may have more information in that area.
Okay, so I'm sure Dr. Rahil have questions for you.
Yes, I especially thank Dr. Alison, such a wonderful lecture and covering lymphatic filariasis from end to end. And yes, there are several questions. I hope I have the opportunity. If there are no other questions from the audience, maybe you can open the floor. But two quick questions which come to my mind. And given your wide and international experience, you have worked in so many countries. In your talk, you have majorly touched upon MDA and its challenges of non-acceptance or poor compliance in the communities. Another bigger area which keeps on worrying me also is mobility management. Even that requires a lot of mobilization of communities and how do they need to do self-care, when do they need to report, how to recognize danger signs. So all these issues require a lot of education of community that can maybe dealt separately. And you are focusing on MDA. And addition of the third drug has actually made it more complex for people to comprehend and understand increasing of the pill load. So that is another one. I want to understand from you basically that you have enumerated all the challenges which are even well known in India, and there might be a couple of more cultural factors layered on it. Have you come across any success story or how to break those barriers? We always talk about the problem. We understand where the barriers are. People will not accept, they will not take, they are feeling healthy, they don't feel the need to it. Our health system is not able to communicate better. So we know the challenges. From India also we know challenges. In fact, Vector Control Research Center is one of our institutes in ICMR which has worked extensively, and the triple drug trial was done by them. The randomized community-based randomized control trial to see safety of ivermectin, which you showed the data from Yadgir, is done by them, and that's how the program adopted ivermectin. Even their social science research shows these challenges are across several cultures within India itself. There are systemic non-compliant people. I mean, they are called systematic non-compliant. Now they are called never treated. I want to know from you in brief, I've spoken too much. Do you know of any success stories? How do we break those barriers? So if we can pick up some clues for India. Similar
Yeah.
developing country from Southeast Asia or something. Countries have eliminated, like with the help of DEC salt, they have eliminated, or from other strategies like China, Sri Lanka. Can we pick up some clues from our neighboring countries? Culture might be little similar, or the climatic factors are similar, geographies are similar. So that is one question. Second is, sorry for being so lengthy in the beginning. COVID has actually spoiled us. Now we feel everything is possible because we have been able to handle COVID. So when COVID vaccinations came, there was so much of energy and money pumped into community, acceptance for COVID vaccines when people were so scared for their life and everything. But again, there were people who rejected COVID vaccinations. But still, there is a country like India, there was vast acceptance of COVID vaccination, but not of drugs. So how do we navigate those rejections by people?
Yeah, no, these are
brief. Thank you.
Yeah, these are wonderful questions. And I really appreciate your question of, we know the challenges, what are the solutions? And I think that's a great point. And maybe I'll redo this talk in the future with the positive examples, because I think that's really important. I'd be happy to share a couple just from my own experience and from the literature. And again, this has really been shown widely in India. And I'm happy to forward papers along. The one that comes to mind is Paul Canty. It's quite an old paper. But I know that Professor Suma is very active in this in Karnataka, not Karnataka, Kerala. But the self-care groups, where we have good self-care groups in a community where people with lymphedema are coming together and being taken care of and looking after one another, we actually see that increases mass drug administration, that will actually have an impact on our coverage, because people are seeing the disease, they're seeing that people are being cared for, and so it has a positive effect on coverage. It's not The program was designed with the two pillars in mind. Unfortunately, we tend to lean more towards MDA, and then we go, oh no, we're getting towards validation. We better look at morbidity management and disability prevention. But if we actually do them as the program was intended, which is looking at them as two pillars that support together elimination, I think we'll have a lot more success. And India has a demonstrated success in this area, and there's been some also recent work in Bihar with Effect Hope, a Canadian organization that's been also very successful and also showing how these self-care groups can also improve the mental health outcomes of individuals living with the chronic manifestations of disease. So I think that's one really positive example. I think a second example I would pull from Indonesia. So in some of the work that we've done there, when you have an area that's facing a lot of challenges, by doing some social research that can act as a kind of diagnosis of challenges, and then working together with the district health authority or whoever is responsible for the MDA to just make slight alterations to the program, can have great success. And you really can see a shift in both you're never treated, so you're reaching people for the first time, as well as increasing your coverage. So I think that Indonesia's had some success where they've really used this kind of quick and dirty, if you like, social research prior to an MDA to help reorient a little bit towards a new message, towards a new distribution. Also would guide in an area where there has been important challenges. So I think microplanning, there's a renewed kind of look at how we engage communities better at that lower level, and microplanning provides a really good opportunity. Thailand and Malaysia. Thailand's been incredibly successful in their elimination programs. And so their program is also interesting to look at, as is Malaysia. Malaysia is very successfully they're dealing with hotspots. Their identification of hotspots is very good in a post-elimination phase in their surveillance. And they're active. They have zoonotic transmission of LF there, and they've been very proactive in carrying out MDA with a triple drug therapy. So Malaysia is also a really interesting country to look at. And then finally, Timor-Leste. Is another country that, and again, much smaller. I know in India it's massive. So when you say Timor-Leste, it's like a suburb of Delhi, in terms of size. But they really successfully rolled out the triple drug therapy. And they really had a very concentrated, coherent campaign in the country that was very successful, and they have done very, very well. And I think what's interesting to look at in Timor-Leste is maybe not necessarily the size of the country, but really how they did it and how they planned and implemented that campaign, could be implemented at a district level or a state level in India. And so I think Timor-Leste is another great example of a country that's seen a lot of success in their elimination program. So there are successes 100% and ways that we can learn from other countries that have successfully moved towards elimination. And then your second question around COVID vaccines, great question. And there's been so much variation in other countries where I'm working. People do not want to take the vaccine at all. So it is so very context specific. Again, I think a lot of it's really communicating with communities and explaining to them how close we are, how possible elimination is, and how we don't need to see this disease that's so old. We can actually get rid of it. And so thinking towards that positive, healthy, modern future, I think, can actually be some powerful messaging at the community level. At the moment, there's no injectables in the pipeline that I know of, so we're stuck with tablets. But I think also the ancillary benefits of those tablets is also important to communicate, and we often forget about that particularly in impoverished communities where there may be scabies, where there may be intestinal helminths, where there may be lice. Particularly, the addition of ivermectin is really important to take care of some of those public health benefits.
Right. So I think, yeah, you have enumerated several, examples which have been success stories across countries. I'm sure India should be able to pick up those clues, and that gives me an idea. We should look into the countries which have been able to eliminate, and what are the strategies they have used to engage communities, and how successful they have been in doing this. I mean, Sachin, is there any other question? Can I ask one more?
Yes, please. Please.
So in malaria now there's renewed interest. Renewed means there's an interest of insecticides as a vector control tool. In the sense they are controlling the parasite longevity in the vector by feeding these insecticides in cattle or even giving it to human beings. So they are not directly managing the infection in the human, but how these insecticides work. And vector control is hardly talked about in lymphatic filariasis. So we are just so tunnel vision on MDA that we forget rest of the players in the game of lymphatic filariasis. And you sufficiently said, even MMTP we don't care about, even though it's one of the equal pillars of elimination. But we will remember it as an afterthought. But vector control is actually a stepchild. Nobody wants to look into it. So, but we talked about endectocides in malaria. Is there a scope of, and WHO also doesn't talk much about vector control, but is there a scope of new thought processes or new things for vector control in lymphatic filariasis? Culex mosquito difficult to control, and it's very high intensity, especially country like India with tropical environment and with poor sanitation and abundant breeding ground available. How do we navigate those difficult situations to cut that thing from the vector part itself? So this is renewed interest in India.
No, I think this is a really important point. And in those areas where there are anopheline vectors and there's high bed net use for malaria, we see a lot better success of our MDAs. So for example, in Papua New Guinea, where bed net use is really high, they have a very successful malaria bed net distribution program together with Rotary International. And so the compliance is quite high for use of bed nets. And so our MDAs are more the duration of and the longevity of the effect is better because of the use of, because it's a benefit of vector control through bed nets. So I think you're absolutely right. The culicine vectors are more challenging for sure. But it is something that we need to be thinking more about. And, there are advantages of vector control in general. So I think it's an area that we have not sufficiently, I think, addressed. And I know there's research ongoing in India, in Papua New Guinea, and in Indonesia, looking at the presence of parasite in the vector. So that is also being looked at as a way to also do surveillance post transmission, post elimination surveillance. So I think it's a good point to mention, and one I think where we need to be putting more effort.
Yeah, thank you. Sachin, any other questions from online participants?
Yes, if allow only one question I can see. How Bacchia targeted drug could be helpful in the treatment of LF? Is there any program in any country?
Yeah, it's a good question, and it is not my area of expertise at all. So I would be careful to respond. But I do know that Indonesia has been at the forefront of this research. And researchers at Gajah Mada have been looking at this. So unfortunately, I won't respond to that. There may be on the call who are more informed than I am, but I am aware of it, and I know that it's been quite successful in Indonesia.
Okay.
So I would look there.
Yes. Okay, so with this, we would like to conclude this session, and I, really appreciate that this is, as you told, this is a weird time for you to talk about, early morning, you are talking about LF in India. But thank you very much, all the participants and Dr. Alison. So with this, we conclude this session, and next lecture would be from Professor Thomas Churchill. He is in Imperial College London, and that is going to be wonderful because he would talk about the mathematic modeling and tools for surveillance and transmission of malaria. So till then, goodbye. Take care.